A very warm welcome to you all. Um, and thanks for joining us for this, the latest installment in our NHS supported Incubator in AI and Digital Healthcare webinar series. I'm Jeff Hogg, a clinician scientist based between University Hospitals Birmingham NHS Foundation Trust and the University of Birmingham. For those of you joining us for the first time, the Incubator is a cross-sector community aiming to collectively advance regulatory science and innovation in AI and digital healthcare. And this demand-led webinar series is our vehicle for knowledge mobilization and getting to dig into interesting topics together. So we can invite experts in who match some of the questions and have expertise and recent research projects in some of the areas of interest flagged by you through your questions and queries, and have the opportunity to dig into these cutting edge projects and swap perspectives and ideas about them. The format of these sessions very much respects that. So we're soon going to be able to enjoy a presentation from our speaker, and we'll be in listening mode for that bit, but we'll have a good chunk of time at the end of the session for questions and for discussion. So hopefully you can see a Q&A button at the bottom of your screen, and just so you're not having to bottle your thoughts as they occur, do feel free to type down any questions there, but we'll dig into them at the end if that's okay. And we'll have ample space for that. And don't worry if we don't manage to get to them, because as I mentioned at the beginning, it's very helpful for us to get a sense of the questions people in the community want to dig into so we can think about sessions coming up. On the housekeeping front, we'll also be recording today's session, and we'll host it on our website too, so you can rewatch it at a later date or recommend it to a colleague who wasn't able to join us today too, if that's helpful. So, moving on to today's talk, a key motivator for many of us on the call in healthcare research and innovation more widely is to deliver public value. And it's one thing to piece together a convincing few sentences to that effect on a research grant proposal or product marketing materials, but quite another to authentically understand what is valued by the public and other stakeholders. This is particularly challenging with new technologies like AI, where the definitions that people hold in their mind often differ, and the experiences and perceptions they associate with those definitions can be even more varied. So, to avoid trying to tell members of the public about what they value rather than listening to them, it's really important that we make time to make sense of some of this complexity. That way, we can understand what good looks like more fully before we work toward getting there. It's hard to think of a clearer or more contemporary insight into those issues than what's provided by the recent update to the Health Foundation's Public and Staff Attitudes Survey. So it's a great pleasure to welcome Nell Thornton to the Incubator today, who's an improvement fellow at the Health Foundation and leads major research projects on the use of new technologies in healthcare and AI and other technologies too. So, if I can hand over to you now, for and to share slides to speak on public and NHS attitudes now in healthcare.
Brilliant.
Uh,
Thanks so much,
Looks like
Jeff. I'm just gonna sort my screen sharing out. Give me 30 seconds.
thanks very much. No,
Those over. Okay, can we see those okay?
yeah, perfect on presentation view too. Thanks very
Brilliant.
much.
Great, thank you. Hi everyone. It's a real pleasure to be here today. As Jeff said, I'm Nell Thornton, and as of yesterday, I'm a senior policy fellow at the Health Foundation. And today I'm going to talk about why trustworthiness, confidence, and engagement matter when we think about AI in healthcare. And I'm going to share some of our recent research on public and NHS staff attitudes. There's obviously a huge amount of excitement about AI at the moment, particularly around its potential to improve productivity, support staff, speed up diagnosis, and improve care. But alongside those opportunities are important and legitimate questions around aspects like safety, accountability, fairness, oversight, and the human aspects of care. And one of the arguments that I want to make today is that the success of AI in healthcare isn't just going to depend on technical capability. It's also going to depend on whether people feel confident in how those technologies are being developed, how they're governed, and how they're being used. So just a snapshot of what I'm going to cover today. So for those who haven't come across this before, I'll say a little bit about what we do at the foundation. I'll talk about why engagement matters, why it matters, what people think. I'll talk through some of our recent and previous research on public and NHS staff attitudes to AI in care, and a little bit about our latest findings and what the public's priorities are. And then to finish off, I'm going to tease some of the more recent research that we've been doing as well. So just quickly then about the Health Foundation. So we are an independent charitable organisation working to build a healthier UK, and we do that in a number of ways. We test practical solutions, we bring people together through convening, partnerships and networking, and we also do research and analysis, and that's what I do. So I lead our research on tech and AI in care. So AI clearly has significant potential in healthcare. We've been hearing that a huge amount, but realizing that potential is not just going to be about developing good tools. It's also going to require coordination across government, between regulators, the NHS industry, and researchers. So it's not enough just to have a health strategy and to have an AI strategy and think that those two things are going to come together. At the Health Foundation, we've argued that the UK needs a more dedicated and coherent AI strategy for health and care. So one that looks not only at innovation and adoption, but also more broadly at the workforce implications, regulation, infrastructure, equity, and public confidence. And we're looking forward to seeing the AI roadmap, hopefully later this year. Because without that wider coordination, there's a huge risk that implementation is going to be fragmented or inconsistent, or is going to struggle to gain traction in practice. But the key to getting an AI strategy right, and the key to getting AI right, is engagement. So if new uses of technology are going to be accepted and their benefits fully realised, it's critical that they command the confidence of patients, the public, and NHS staff. So one of the key points that I want to emphasise today is that AI in healthcare is not purely a technical issue. So these technologies are also raising important questions about values, about priorities, and about trade-offs. So for example, questions like, what kinds of decisions should AI support? Where should human oversight sit? How much uncertainty or risk is acceptable? And how should benefits and risks be balanced? And public confidence matters because it shapes whether those technologies are accepted and whether they're used in practice. NHS staff confidence matters because staff are ultimately central to implementation, to uptake, and to safe deployment. And engagement is important, not just because it's going to help policymakers understand concerns early, but because it will help build legitimacy and shape better governance approaches. But I think, and I've heard quite a lot, there's sometimes a tendency in these discussions around AI to frame trust primarily as a communications challenge. The question kind of generally boils down to, how do we persuade people to trust us and to trust these technologies? And I think that framing can often be quite misleading. The issue that we need to contend with is not simply whether we can get people to trust AI. The more important question is whether AI tools and the organizations using them actually deserve confidence, whether they are trustworthy. Because research has shown that when tech, like AI, is perceived as high risk, it actually doesn't matter how persuasive we try to be about its benefits until people feel reassured that, for example, those tools are safe, fair, evidence-based, accountable, and properly governed, they will likely discount or even outright reject those benefits. So it doesn't matter how much we talk about what the benefits are, until we de-risk those technologies in their minds, they're not going to listen. So engagement here is not about convincing people to accept AI regardless of their concerns. It's about understanding what conditions are needed for their confidence to be justified. Because trustworthiness is built through the choices that we make around design, regulation, oversight, and implementation. not just through messaging alone. And I also want to address another comment that I've heard quite often in the few years of doing this research, which is generally along the lines of, well, people don't know much about AI. Awareness of AI or its technical capabilities is really low. So shouldn't we leave it up to the experts to decide where AI is best placed or when it should be used or what is needed to make sure it's safe? So in many ways, yes, that is right. People don't know very much about AI. Does that mean that their opinions aren't important? And to that I say no. So opinions don't need to be well informed to be opinions. And opinions don't need to be well informed to have power. And I'll let you all judge what I'm referring to there. You know, people don't have to be technical experts to have legitimate views about AI in healthcare. Most people aren't experts in machine learning or in regulation, but they are experts in their own experiences of receiving care, of using services, and of understanding what makes them feel confident or uncomfortable. And those opinions will shape adoption and legitimacy of technologies, whether or not they're highly informed. And that's why engagement matters. So it helps us understand not only what people think, but also what sits underneath those views, including their concerns around fairness, transparency, accountability, or the role of human judgment. And this is so particularly important in healthcare, where trust in institutions and relations is so important. Those perspectives cannot be treated as secondary to technical expertise. So hopefully I've made the case for why engagement matters. And with that in mind, I'm going to move into some of our findings on public and NHS staff attitudes towards AI in healthcare. This work, I've drawn on a variety of findings. We've done 3 years of this research now. Our most recent work is based on a large-scale survey of over 10,000 people. One of the interesting things that we've found here is that attitudes are often more nuanced than either the very optimistic or the very pessimistic narratives that we sometimes see in public debate. I'm going to talk you through some of our key findings now. So for the methodologists among us, so just to be clear what we did, so we surveyed this year just over 10,000 respondents. 8,000 of those were representative members of the UK general population aged 16 and over, and just over 2,000 of those were NHS staff members. If we break down our general population sample, so 7,760 were sampled through an online survey, but we also sampled a booster sample, of 240 people who were at risk of digital exclusion, and they were surveyed through computer-assisted telephone interviewing. We determined them to be at risk if they met a minimum of 2 of 3 of the high-risk factors for being digitally excluded. So that's no post-18 education, over 65 or low income. And our NHS staff sample was split into 6 professional groups, so medics and dentists, nurses and midwives, due to healthcare scientists, other clinical services, so that includes people like healthcare assistants, admin and clerical roles, and allied health professionals. So we're going to start by looking at some of the survey results, I think kind of overall sentiment, so not yet breaking it down by any demographic groups. So what we found is that overall, attitudes towards tech and AI are on balance positive, but they are relatively finely balanced. So one of the questions that we ask people is, which of these statements best describes how you feel? I think that using either technology or AI will either make the care quality worse, make the quality of care better, or not impact the quality of care. So this one's here is just looking at technology. So the blue bars on the right are the number of people who said that using technology makes care quality better versus those who don't. And you can see actually on balance, most people do think that tech improves the quality of care. And in 2025, we saw a slight increase in that number of people. We did also see a slight increase in the number of people saying that tech will worsen care quality. And that's likely because over the last year, those people who are perhaps unsure have started to make up their mind and have moved one way or another. But what about AI? Are people kind of more convinced that it'll improve the quality of care or less convinced? So looking just at the public, you can see here that people are generally less convinced that AI will improve the quality of care compared to technology more broadly, but they are still on balance positive about the use of AI. And again, we've seen that slight growth in the number of people saying it will make things better. So how do they compare to NHS staff? Are NHS staff more positive or less positive? So looking at the same questions then, looking just at technology, you can see here that on balance, NHS staff are more positive. So the more of them think that technology more broadly will improve the quality of care. So 61% in 2024, 60% of those we asked in 2025. You'll see there's been a notable growth in the number of staff saying that they think technology will make care quality worse between 24 and 25. Again, that's made up of those people who weren't quite sure the year before. They have predominantly gone into kind of it makes it worse. And then on AI, so same story, so less positive about the impact of AI on care quality versus tech more broadly, yet still more confident than the general public. So this year, 57% of the staff we asked believe that AI will improve the quality of care. So it's a relatively optimistic story. We're not seeing any sort of outright rejection of AI as a technology. So some of the other questions we asked were, we asked people to kind of ask the extent to which they agreed or disagreed with a series of statements. And we kind of took away lack of support from support, and you can see here a net score. So anything to the right of that line means that people generally agree with that statement. Anything to the left of that line means they generally disagree with that statement. So this reads red bars of the public. So you can see on the statement, AI is safe to use for patient care. The public, on balance, believes that to be true at +9. On the statement, AI systems will make the right decisions about patient care, +3, so not as strongly positive, but still on balance, people tend to believe that AI systems will make the right decisions. But on the question, AI systems are more accurate than a doctor at diagnosing illness, that's -12. So people are not yet convinced that the AI is more accurate than a clinician when it comes to diagnosis. So how do staff compare? Well, when it comes to AI is safe to use for patient care, is +48. So staff significantly more likely to believe that AI is safe to use for patient care. They're also significantly more likely to think that AI will make the right decisions about patient care. And they're also more likely to believe that an AI system is more accurate than a doctor at diagnosing illness. So again, continuing that story that generally speaking, staff are far more convinced about the potential of AI than the general public. But that's not to say that that sentiment among staff is universal across all professional groups. This is from our 2024 data. We asked staff to tell us the extent to which they agreed or disagreed with the statement, I look forward to using AI as part of my job. And the average was 57% of staff saying, yes, I agree, I look forward to using AI. But there were some groups who were more optimistic than that. So the medics and the dentists are generally our most enthusiastic group, 67% of them saying they're looking forward to using AI, followed by allied health professionals at 62 and healthcare scientists at 59. So the groups that are generally below average, who are less supportive, but still on balance, supportive, nurses and midwives at 54, admin and clerical staff at 52, and other clinical services at 51. So it's important when we're thinking about the rollout of AI that we're looking at staff in their professional groups as well as just broadly overall, because that can have a significant impact on uptake. So one of the other things that we've found is that support for AI does tend to vary based on how it's being used. So given that we know that the public are more cautious than staff when it comes to AI, and they're also a bit more reserved about its impact on care versus tech more broadly, how might that play out in practice? So we also know from our research that support for the use of tech and AI varies based on how it's being used. And one thing that we explored with people was how happy they were to use the NHS app for a range of intended purposes, because you'll know that more use of the NHS app is central to the 10-year plan. And so you can see here at the top of this chart, so 3/4 of people are happy to use the NHS app for things like booking appointments, choosing their preferred hospital, or giving feedback. But are they happy to use it to get health advice from an AI tool for non-urgent problems, i.e. the doctor in your pocket? So you can see here, if I click forward, at the bottom, so on balance, yes, 49% of the public are happy to use the NHS app for this purpose, but it's much lower than some other uses and it's much more finely balanced. So nearly a third of the public are saying they would not use an AI tool through the NHS app to get that advice. So meaningful engagement with the public here is going to be essential to get this right. So what might be some of the reasons why people are worried about things like getting AI advice or using AI tools? So one of the other questions that we asked was, to what extent do you agree with the statement, AI systems will make me feel more distant from either healthcare staff if you're a patient or patients if you're healthcare staff? So looking at the UK public first, what we found was 53% of the UK public think that AI is going to make them feel more distant from healthcare staff. And then when we ask staff, so we know they're generally more supportive of AI when compared to the general public, but that said, they feel it even more. Almost 2/3, 65% of the NHS staff that we surveyed are worried that AI systems are going to make them feel more distant from their patients. So what impacts might having a human in the loop make on the extent to which people are happy for AI systems to be used? So for this question, we had 6 different scenarios. They're at the bottom here, they're slightly truncated for the graph, but they're essentially creating letters, recording appointment notes, predicting when I might get a disease and offering me support, supporting a diagnosis, deciding when I'm seen, or helping choose my treatment. Our public sample was split in half, and half were asked to tell us how happy they would be for the NHS to use AI for that situation, for that scenario, if the decision was going to be checked by staff. The other half were given the same scenarios, but were told that staff did not intend to check that decision. And then what we did is essentially we worked out the net score. So anything above 0 means that it's supported. Anything below 0 means that it's not supported. So looking first at those scenarios where the decision intends to be checked by staff, you can see here actually all net positive. So we know that the public are more supportive of AI for admin than they are for patient care, and that shows here. So creating letters and recording appointment notes have net scores of +39, +36. And things like triage and choosing treatment is less supported, but still on balance supported by the public if staff are going to check those decisions. Well, what about if we take that human out of the loop? What if staff don't intend to check that decision? What difference might that make? Could be one of several things, right? So maybe trust will go up because people think AI is more accurate than a doctor. People are more convinced that it'll make the right decision. Maybe it won't impact at all. Maybe you'd see a slight reduction in that trust levels, or maybe you would see a complete withdrawal. And what we found was we asked them these scenarios but took staff out of the loop. In almost all scenarios, support for the use of AI fell below 0. The support was essentially withdrawn. The only one that remained positive was the creation of letters at +2. But things like supporting diagnosis went from +19 to -40, choosing treatment +15 to -40. So it just shows the massive impact that it can have on trust and support for the use of AI when people feel like that AI is potentially operating autonomously. So that's some of our key findings, kind of looking at the population as a whole, but we've also found some really interesting things when we start to dig into some of the demographic splits. And there's three particular groups I want to touch on now. So one of the questions we get is, well, how do women feel about it? Is there a gender difference? And this one might not surprise you. So one of the questions that we asked was, how supportive, if at all, are you of the NHS using AI for patient care, like helping to diagnose illness or recommend treatment? And what we find is on average, 54% of the population are happy for AI to be used for patient care. But when we break it down by gender, there's an obvious difference. So for men, it's 61%, and for women, it's 48%. We consistently see that women are more skeptical of the use of AI in healthcare compared to men. Now, this is quantitative research, so we have to be careful about drawing any sort of causative links, but there are some other questions in our surveys that might shed some light on why they feel this way. So some of the other kind of agree, disagree questions we asked showed us that women are significantly less likely than men to think that AI is more accurate than a doctor at diagnosing illness. They are significantly less likely to think that AI is going to make the right decisions about their care. And they are significantly less likely to think that AI is safe to use for patient care. So going back to that point earlier about when people perceive technologies as high risk, they are less likely to see their benefits. It's likely what we're seeing here. It may be that women are kind of seeing the risk of these technologies more and are therefore much less convinced about their potential for their care. Another group that I wanted to draw attention to is looking at socioeconomic groups. So this is our kind of socioeconomic group classification from A to E. So A, B, they're kind of higher professionals. This is done by the occupation of the highest earner in your household. If it's AB, it's likely to be kind of a lawyer or a doctor or a higher trained professional. And DE are people who are more likely to be on low income or no consistent income. So back to that question, I think that using AI will make the quality of healthcare better. You can see here in 2024 that there's a clear kind of gradient across those economic groups. So those in AB are significantly more likely to think that AI is going to improve the quality of care. So how did that change in 2025? We know that overall, more people felt as though AI was going to improve the quality of care. So have we seen that line shift up across the board? You might be guessing, but the answer is no. What you can see here is that that increase in the number of people thinking that AI will improve the quality of healthcare is essentially being driven pretty much entirely by people in socioeconomic groups A and B, a little bit from C1 and C2. So generally, support for AI is growing among people who are more likely to be on higher income, who are more likely to have stable roles that are less at risk of automation, is generally where that support is coming from. So just staying on this then, so obviously it's really important that we're engaging with all groups when we're talking about AI, and that last finding really emphasizes the need to do that. One of the things that we hear quite a lot when we're talking about engaging with people in socioeconomic groups, DE, is about the financial barriers, and that is absolutely true. They are more likely to be unable to take time off work, for example, in order to participate. But is that the only barrier? Is it enough to kind of give a voucher or some money and think that that'll do, that will improve representation? So last year, one of the questions that we asked was, how willing would you be, if at all, to take part in the following activities, assuming you had time to do so? So taking out time is a factor. That red bar is the number of people saying, I would be willing to do this without being paid. The blue bar is, I'd only do this if you paid me. And the purple bar is, I would not be willing to do this, essentially, even if you paid me. And we asked them across 5 different scenarios. So keep an eye on the purple bar. This is the number of people in socioeconomic groups DE who wouldn't do that activity even if you paid them. So would they complete the survey? 10% of people said no, even if you pay me, I'm not going to complete a survey. Now, it's not drastically different from those in other socioeconomic groups. What about testing a new technology at home and providing feedback? 21%, so a fifth, people in that group wouldn't do that. 28% wouldn't test a new technology in a hospital setting and provide feedback. 38, my eyes aren't great, 38% wouldn't participate in a workshop, and 42% of people in socioeconomic groups DE would not attend a group discussion to help you develop tech, even if you paid them. So this is showing that those barriers to engagement, those barriers to participation are not just financial, they are social and they are cultural, and we really need to be taking that into account when we're looking at how we develop technologies. So what about age? This is the last group that I want to draw attention to today. So often what we hear from people is, young people are fine. They love technology. That can never get them off their phones. They're always, 3 centimeters away from a smartphone or from social media. Does that translate into therefore being more supportive of AI? So thinking again about that question, I think using AI will make the quality of healthcare better. We've got age running along the x-axis there. So just keep an eye on that red line. You can see here, young people, 16 to 24 age group, are significantly less likely to think AI is going to improve care. Across all the questions we ask, they are consistently one of the most skeptical groups. Young people are absolutely not as convinced as other groups that AI is going to be good for their care. So any assumptions that we have about young people's use and about kind of thinking that smartphone use or general technology awareness will translate into support, we need to be challenging some of those assumptions. So just touching then on one of the other questions that we asked this year. So obviously we know that introducing tech and AI into healthcare is no mean feat, and it often involves difficult choices about what we value the most and what might have to change in order to reap the benefits that are on offer. For example, is it better to have stricter rules governing AI's use, even if that potentially deters companies from developing AI in the UK? Or is it better to have more relaxed rules that could encourage companies to develop here? Now, those questions are as political and ethical as they are technological, and how the public feels about them matters, because as we know, when they see those technologies as high risk, they're going to discount or reject their benefits. So to test this, we ask the public to weigh up 5 trade-offs that policymakers, NHS leaders, health professionals and AI developers might face, and we did see a bit of a pattern emerge. So when asked to choose, the public tends to prioritise safety, oversight and assurance over speed or economic opportunity. So when we ask them to choose, you can see on these graphs here, 71% of the public think that it is more important to have strict rules in place, even if that stops companies from developing AI in the UK. 72% would rather wait until there is more evidence to prove that AI works, even if it means they have to wait longer for those technologies to become available. And 70% want a human to check the results of the AI analysis, even if that means they have to wait longer to get their test results. But the other 2 trade-offs that we asked about were slightly more balanced. So as we saw in previous questions, while the public do think it's important that they get their health advice from a person, 45% of the public think it's more important to get that advice quickly, even if that comes from AI. And on the question of whether it's more important that the AI is accurate or that it's explainable, that's a real tension that we see in black box systems. The public are split 50-50. So it shows that opaque systems might struggle to build trust, reinforces the importance of considering how AI is being integrated into care pathways. But across all of these results, what has become abundantly clear is that AI is only going to take root in the NHS if it earns our confidence. So just to finish then, just to tease some research that's coming out later in the year. So this year we have worked as the research partner to the MHRA's National Commission into the Regulation of AI in Healthcare to provide new insights into the public's views on the principles underpinning AI regulation and how to build public trust. So this was qualitative research. This has got us closer to being able to answer some of those why questions. The things we were exploring are, what do the public believe should be the primary aims and outcomes of AI regulation in healthcare? How would they prioritize those outcomes and trade them off against each other? What factors might shape their perceptions of whether regulation is trustworthy? And what conditions, safeguards, or oversight approaches do they think are needed in order to have confidence in the use of health AI? So what we did was we had 75 participants in 3 cohorts across the country, one in York, Milton Keynes, and Cardiff. We selected those locations because they offered us the best diversity in terms of demographics, political perspectives, but also geographical typology. So, for example, kind of post-industrial towns or affluent established cities. And what we did here is we used deliberative methodologies. So not just snapshotting how people feel in that moment, but actually giving them input, time, information, and expert interaction to move us beyond their initial reactions in order to kind of get to considered, consensus-driven discussion on these complex issues. We did it over 3 workshops. So they had an online evening workshop where we explored their baseline awareness. We gave them plain language introductions to what is AI regulation, what do MHRA do, for example. And we gave them 3 use cases to think about: ambient voice technology, mental health apps that use AI, and skin cancer detection tools. We then had an in-person all-day session with them where we used those use cases to discuss trade-offs around accuracy, speed, human oversight, transparency, explainability, and equity. We talked about what the regulator's role was in driving innovation and how they felt that should balance against regulation. And we also discussed different regulatory approaches. And then we had a final online workshop where we developed some principles, which we then tested with them. So I'd love to be able to talk you through the results, but we're still analysing them. The full publication will be out towards the end of the summer, and I look forward to sharing that with you. If you want to read more about our quantitative attitudes work, they're on our website now, including our most recent publications, our broader findings, and also my blog talking in more detail about those trade-offs. And if you'd like to talk any more about this research or our broader work on tech and AI, then please do just get in touch. And thank you so much for listening.
Thanks so much, Nell. That was brilliant and so relevant to so many different programs of work. Thanks for talking us through. I'm going to come to the questions in the chat, but at the top, I failed to give a heads up to our audience members that I'll try, if Zoom behaves, to unmute people so they can speak to their questions, but I can quickly step in if that doesn't work out, depending on where you're sitting. But I'll start with one of an anonymous question that's come in, which is kind of leaps off your closing slides about whether AI technologies, when they fall within the scope of a regulator, if that builds trust and confidence in the public. The question is posed around the MHRA as a regulator, which would be great to hear your perspectives on, but also I'd be interested if you thought health service regulators like the CQC or perhaps information governance regulators like the Information Commissioner's Office have a similar kind of effect in the public mindset, or any kind of reflections you have around that.
Yeah, it's a great question. So I think from the deliberative work that we did with people, obviously part of that was explaining to them, what is a medical device and when is it classified, when is it in the remit of the regulator to keep an eye on that. People were sometimes actually quite shocked that there are some devices out there that aren't within the remit of the regulator. So, for example, some uses of ambient voice technology, if they're not summarizing, they're just transcribing. Things like direct-to-consumer devices and how some of those fall through kind of into the grey area of those definitions. So, in a way, like classifying something like ABT as a medical device, I don't think we'll necessarily see a massive uptick in confidence. I think people would be more shocked to know that that wasn't already done, in the same way that when you talk to people about linking health data and their instinct isn't, oh, that's great, are you telling me you weren't doing that already? So yeah, I think there's that. And actually just it takes a lot actually for a member of the public to understand what is a medical device, what is regulation, what's the role of regulators. So there's a communication exercise to do there to actually grow awareness of what these concepts are and why they matter, in order for people then to see the impact of any changes to those. But Jeff, just coming on to your question around kind of other, so kind of professional regulators and organizational regulators, I think they all absolutely have a role. And really the only way we're going to see any discernible growth in public confidence is if people think that all of these regulators are pulling in the same direction. Generally speaking, the public don't know the difference between a product regulator, a sectoral regulator, a professional regulator. They expect regulators, and they mean all regulators, to be doing the right thing for them. And that's what they need to see. So that's what we need to be focusing on. And a lot of that's going to be around coordination. And I'd say we probably need to see more of that.
That's really helpful. I might just to kind of build on that a bit more, bring in Fiona McKenzie, who's got a great question about how we kind of move forward to build trust. So I'm going to try and unmute you, Fiona. Hopefully, you can speak.
Okay, can you hear me?
Loud and clear. Thank you.
Fabulous. Hi, thank you. That was an excellent presentation. Delightful to hear it. So my question is about the kind of what we know, or what you know about what has driven those results, particularly around trust and confidence in AI for public and for staff. And then I guess, what does that tell us about what we need to do to build or grow trust and confidence in AI?
Yeah, it's another great question. Now, obviously, quantitative research is limited in kind of giving us those clear steers on what people want to see, but we've done a lot of talking to people and a lot of wider research, which is pointing in a relatively clear direction. I mean, generally speaking, trustworthiness is built not just by having rules or regulations in place, but by being seen to enforce those. So certainly from a regulatory perspective, the public want to know that companies are not above the law, they're not above regulators. So often what you see kind of upticks in trust, if you see BBC News articles about companies being fined by regulators, that will grow trust because people are confident then that a regulator is doing something. Trust is generally eroded if people feel as though information is being kept from them. So kind of ambient voice technology is the absolute classic case at the moment. So like people finding out after an appointment that AVT was used, or people not having the opportunity within the appointment to ask questions about it. Often they get in the room and the GP says, I'm using AI to record notes, is that okay? And they'll just go, yeah, because they're there to talk about their health, they're there to talk about their problem. They don't want to use time to talk about, well, where is it stored and who has access to that? And how long do you keep it for? And where does it go? And who sees it? And can I see the notes after it's done? No one's answering those questions for people. And while they can't get those answers, we're not going to grow trustworthiness in us as institutions. So there's something about what information is available, how is it available to people, do they understand it, and do they have the ability to ask questions, not in the 9 minutes of a GP appointment that they have left.
Thank you.
Thanks. No, that's a great answer and a great question, Fiona. Thank you. Next, Haley Jari, I'm going to try and unmute you. Thank you for both the question about kind of professional threat from AI and also the link you dropped in there. Can you try speaking, see if we can hear you?
Hello, can you hear me?
Perfect. Over to you.
Yeah, I was just wondering, like, based on your results, do you think the admin and clerical staff would not be excited to use AI because they think their jobs are the ones that are most likely to be replaced by AI? And then I saw this in the news this morning about the NHS planning to scale back recruitment drive and use AI to avoid financial ruin. Obviously, clickbait headline, but like, admin jobs are, the ones that the public said that they would most trust, like writing letters and things like that. So the public say they'll most trust AI to write a letter, which means the admin staff then could potentially, be reduced.
Yeah, I mean, how topical is this, right? Like, it's happening right now. So interestingly, a few years ago now, so before Gen AI was really a thing, we commissioned a study through the University of Oxford to try and work out what roles in primary care could be fully automated. And the answer came back as none. There were no roles in primary care that could be fully automated, because it's really hard to like define, like, one person does so many different things, and actually, like, does somebody have a job where 100% of those tasks could be fully automated? And the answer then was no. I suspect if we were to do the research again now, it would have massively shifted. But in some ways, I feel like the answer is still no, because being an administrator often, particularly things like primary care, it's not just sitting behind a desk and typing up letters. There's patient engagement, there's talking to people over the phone, there's reassuring people, there's a human interaction that still cannot be replaced by AI. And I feel like we're so busy asking the question if we could do it, not enough people are asking the question, should we do this? Should we be substituting these roles with AI? Care without a person, is it even still care at all, really?
Yeah,
it's so much more than that. And I think we keep getting wrapped up in this narrative of inevitability. So, like, AI technology is improving, it's going to do amazing things, kind of get on board or get out of the way because it's going to come here. But it's up to us. It's up to policymakers. It's up to institutions whether they use it. We don't have to replace staff with it if we don't want to. And actually, I'd argue that it's somewhat of a fallacy that it's going to save you money. Most companies that we've seen, so there's a study done recently that showed in broader, so not just in healthcare, but 95% of companies that had tried to use AI had seen no return on investment within a year. It's not just a case of buying a tool and shoving it in and thinking it's going to replace people and save you loads of money. We know that's not true. We did a study at the Health Foundation. So we asked clinicians, if you had 1 hour back from technology, like, how would you use that hour? And the policy assumption is that 100% of that hour back is going to go on patient care. And actually what the clinicians told us is only 27% of that time was going to go on patient care. We need to be challenging these assumptions about what AI can do, whether people are replaceable, what is the role of the human in delivering care. And, we all need to be asking that question. And that's where engagement really comes into its own. I hope that answers your question.
Yeah, thank you.
That's great. Thank you very much. Next, Robin Cafferata, I'm going to unmute you if that's okay. Thanks for your questions. If you could pick one to run with, that'd be great.
Yeah, I guess I'll go with the question around. There's a few different topics which I think have come up in conversations I've had with sort of patient groups and advocacy and things that are linked. One is AI, and then one is sort of other aspects of sort of data security, patient choice about how data is used and how their data is used. So I was wondering if there was anything in sort of the work you've done looking at how other issues in the NHS, thinking strongly about Palantir and people who aren't comfortable with their data being used by Palantir and things like that, and if that has an impact on AI data use and things like that.
So again, a very topical question. So we have a section in the survey that specifically asks about data and how people feel about things like their data being used. So one of the questions we ask is, like, kind of, do you trust these institutions with your health data? And what we consistently find is that at the top are GP surgeries, and local and national NHS organisations. 2/3 of people trust their GP surgery with their data. At the bottom of the list are local and national government. About 1/3 of people trust them with their data. But interestingly, in the middle of the list, so one of the kind of categories we give are like companies that process your health data. And we don't give examples because that will bias people, but they tend to be 50-50. And it'll be interesting to see this year when we run this again, whether we've seen any shift in that. But over the last few years, actually, public perceptions of companies, and even things like health tech and pharma companies, are in that 50-50 space. They're more trusted than local government. One of the questions we ask is, how confident are you that the NHS is kind of storing your health data securely? Most people think they are. We've asked this survey in the middle of massive press coverage of NHS cyber attacks, the public still think they trust the NHS with their data. So what we tend to see is actually for as long as there is an NHS lozenge on it, the majority of the public will trust the NHS with their data. They've also shown that most people on balance are happy for their data to be used to develop AI technologies. So often when we see kind of pockets of this outrage in the press, it actually doesn't really translate into public mood as quickly as that. But we will have to see whether that's changed this year with increasing kind of coverage around Palantir. So yeah, watch this space.
Thanks very much. Next up, I'm going to come to Joe Thompson, if that's okay with you, Joe. Hopefully you're unmuted. Just give that a go. Well, that sounds promising.
Yeah, sorry, had a load of flurry of pop-ups just then. That was really interesting now, and I'm gutted that I landed halfway through your presentation because I wish I'd seen the first half. But from the half that I did see, I think it's really insightful, and I was just wondering, how are your findings used to influence and generate policy at a local and national level when it comes to AI and use of tech in general?
Yeah, well, Joe, all I can say is I'm trying my best. Yeah, so we obviously we actually, so the first iteration of the survey in 2023, we actually co-developed with NHS England. So we spoke to them about what questions would actually be helpful for us to ask. We're a completely independent organisation, but we wanted to make sure our results were as useful as possible. So we did do that with them. Actually, one of the things we've managed to do, I think, I'm cautious about crediting any sort of credit to us because these things are often more complicated than that. But one of the successes I think we've had is actually embedding responsibility into the way that people talk about AI. So a few years ago, we found that no one was really talking about responsibility. And what we mean by that is, like, it's not just saying, yeah, we'll use AI and like, yeah, obviously it'll be ethical. And everyone goes, yeah, we'll tick the ethics box. What we're saying is like responsibility has to be baked in from the outset. And part of that is understanding how people feel about it and working with them. We really championed that as a perspective. And now that's hopefully being integrated into the roadmap and we're seeing in more and more conversations that we're having. So I think slowly but surely we're starting to change some of that conversation, but it's people like yourself coming to events like this and hearing about it and telling others and spreading the word that will hopefully change things for the better.
Yeah, that's awesome. I'll definitely be taking it back to my organisation's AI strategy group. So thank you.
Great. No, thank you.
Thank you very much. Next, I'm just looking for Jawad Ahmed. I'm just going to bring you in, unmute you. Hopefully you can speak to your question there. Thanks for waiting.
Hello. Hiya. Thank you for that presentation. That was really insightful. I've got a two-part question, if possible. So, as AI moves from more administrative tools such as AVTs and moves towards clinical decision support, do you think having a shared infrastructure of tacit clinical knowledge could contribute to that structured that clinical decision support tool evaluation? And then just following on from that, do you think that would give patients and staff more of an understanding as to how that AI tool performs compared to their colleagues or their existing clinicians that are a reference point for them?
Yeah, that's a very technical question. It's not one I'm gonna try and blag an answer to. If I'm honest with you, so just on the first point around moving from kind of non-clinical towards clinical, like CDSS applications, I'd actually argue that what we've largely seen is moved the other way. So by and large, about 80% of the AI that we're seeing in practice is radiology AI, is clinical AI. It's a very small percentage is used for non-clinical. It's one of the things that we called for a couple of years ago, actually, was a rebalancing of this with kind of, in what other sector would you see the first applications of a new technology being used in the highest risk scenarios? Yet that was kind of what we were doing. We were diving straight in at the clinical, and that's where all the money was going. But actually, non-clinical needs more investment, and it's great to see that is starting to happen. In terms of shared infrastructure, that's not a question I'm able to answer. It's a really fantastic question. I can possibly think of some smarter people than me that would know the answer, and I can certainly put it to them and get back to you.
Thanks, Nell, and thanks, Gerard. We'll park that one for another time. Just before we close out, I'm going to ask one final question, if that's okay. Really curious, in your experience across all this work and over the last 9 years, we were talking about your experience in AI research. Right now, how helpful or problematic do you think the term AI is as a vehicle for asking all of this? Because there's so much kind of conflation and misunderstanding or different perspectives that come in, but at the same time, we need to communicate with each other. I'd be really interested to hear any kind of reflections around that.
Oh, what a question. So one of the first research projects that I did around AI was actually looking at how AI is characterized in policy. How do we talk about it? And therefore, the impact, so how we talk about I affects what policy actions are justified, right? So I'm getting blinded by the sunshine. So what you tend to find is that people use the term AI because it essentially sounds futuristic. It sounds really engaging and like, oh, and so what it kind of leads people to conclude is this is the future, this is the solution, isn't this amazing? This is completely different to what we've had before. But the reality is actually, like, we've had technology for a long time. This is just a different iteration of technology. There is still a huge amount of value that we can get out of the technologies that we have in our hands before we have to dive into looking at these brand new ones. I mean, look at how much more we could get out of electronic patient records, for example. The NHS is still Europe's biggest purchaser of pages and fax machines. Are we really ready for the AI revolution? Is it really here? And often actually a lot of the barriers to AI uptake are the exact same barriers that we've seen with tech adoption for the last 10, 20 plus years. It's decent data sharing infrastructure, it's workforce skills and capability, it's having the right policy, it's having things like the right kind of like tariffs and investments and having money available for adoption. So in many ways, we're just putting a very shiny new label on the same technologies and the same problems we've always had. I think AI is a massive selling point for companies. A lot of people call it AI and it's not. And I think we need to get a lot smarter about knowing when it is and when it isn't. Often it's just an algorithm. And they say, yeah, it's AI and it's not. So I think the NHS needs, like, we all need to just get more aware of what was being sold to us and being able to see behind the curtain on that one. But that said, if calling it AI means that the NHS gets more money for tech, gets more money for implementation, gets more money to think differently about how to do things, then it's not necessarily a bad thing. But we all just need to be savvy about how that's being done.
Thanks so much. And I'm sure you can see from the deluge of questions and general positivity from the audience, we're all really grateful for you making time to talk us through that this afternoon. I really enjoyed that.
Thanks so much for inviting me. It's been great to be here.
Thank you. Yeah, I'm looking forward to getting the recording up too on the website. So just before we close out, I just want to give people the heads up that the next session is on Wednesday, the 24th of June at the usual 4 p.m. slot. And we're being joined by Jess Morley, Associate Research Scientist from Yale Digital Ethics Center, who will be talking us through some really recent work she's been leading on the complexity or how to assess complexity of different AI health technologies and organizational maturity for adopting them too. So big thank you again, Nell, to you, and thank you to everybody for joining us, and enjoy your evenings. Bye.